Yeah, Ann Chang and I have been running Smilow Shares with Primary Care Zoom lecture series. And the idea is that we are focusing on areas of overlap between primary care and oncology, whether that's cancer screening, cancer diagnosis, figuring out what to do with something that might be cancer, or following up after somebody's recovered from cancer. This is our third year, and today's session is just as wonderful, if not more so, than all of the others. And I think you will find it excellent. The topic is pancreatic cysts and cancer. As you know, we're finding a lot more pancreatic lesions, and lots of guidance is needed, and it is here today. As always, we are joined by an NEMG primary care colleague, as well as specialist from Smilow Cancer Center. I'll introduce Flora Zarcu-Power, who is a colleague at Northeast Medical Group. She is a graduate of the University of Medicine in Carol de Villa, Bucharest, Romania, and completed her internal medicine residency at New York Presbyterian Hospital in Queens. She joined the medical staff of Yale New Haven Hospital several years ago as a hospitalist before joining into our community practices in Milford. She's now both a practicing physician and a managing partner of PriMed, which is part of a Northeast Medical Group. She's an active member of the Milford and Bridgeport area medical community. She's served on executive medical staff committee at Bridgeport Hospital and participated in the emerging leadership program through the Yale School of Management. She's a full-time active clinician and helps lend her expertise to primary care workflows and especially the care signature pathways, where she has helped to author more than almost any other primary care clinician that works with us. She strongly believes in sacrosanct doctor-patient relationship as a keystone to great health outcomes, and I think that will come through today. And I'm going to turn it over to you to introduce our Smilow colleagues.
Thank you, Karen. And as always, a pleasure to host this with you. And we have a great program tonight. So we have Dr. James Farrell, Professor of Medicine and Surgery and Director of the Yale Center for Pancreatic Disease. He's an internationally recognized expert in pancreatic disease treatment and research. In addition to his clinical work on the endoscopic evaluation of autoimmune pancreatitis and pancreatic cysts, he's also known for his development of personalized therapy approaches for pancreatic cancer and early detection biomarkers for pancreatic cancer. He received his medical degree from the University College in Dublin, Ireland, graduating first in his medical school class. He completed internal medicine training at Johns Hopkins, and then both gastroenterology and advanced therapeutic endoscopic fellowship at MGH and Harvard Medical School in Boston. After fellowship, he went to UCLA Medical Center, where he developed the largest endoscopic ultrasound program in California and became a founding member of the UCLA Center for Pancreatic Diseases. And in 2013, he was recruited to lead the Yale Center for Pancreatic Diseases at the Yale School of Medicine, while also joining the existing Yale Interventional Endoscopy program. He currently directs the Smilow Cancer Center High-Risk Pancreas Cancer Early Detection Clinic and the Yale Digestive Health Pancreatic Cyst Program. We also have Dr. John Kunstman, and he's MD MHS. He's a board-certified surgeon specializing in the care of patients with cancers or benign diseases of the pancreas, liver, bile ducts, stomach, and intestines. He attended medical school at the University of Wisconsin School of Medicine and Public Health. Dr. Kunstman completed residency training in general surgery at Yale, as well as a fellowship in complex general surgery, surgical oncology at Memorial Sloan Kettering Cancer Center in New York City. And he also holds a master's degree from Yale University. He has a special interest in the treatment of patients with cystic diseases of the pancreas, and he maintains an active research program at Yale examining development of such cystic lesions, as well as the genetics of those of associated pancreatic cancer, and is seeking to improve the outcomes of those patients undergoing pancreatic surgery. So thank you all for attending. And I'm going to hand it over to Flora.
Thank you, Anne. Thank you, Karen, for the warm introduction. I'm delighted to be here with my colleagues. And I want to say thank you to all those tuning in. So why are pancreatic cysts being identified more? Well, virtually every American that goes to the doctor with abdominal pain gets an abdominal CT. Or if you roll through ER, you might be getting a CT, even if you don't have abdominal pain. So one study years ago showed that 2.6% of patients found to have a pancreatic cyst on CT scan. If you add abdominal ultrasound, MRIs, eventually this leads to a good number of cysts that are identified every year, more than 500,000. Next slide. What is the challenge? Well, there's multi-faceted challenges here. So one, finding a pancreatic cyst is concerning for the patient and their family. With patients having access to the health record on the system, they might be reading actually their CAT scan even before you get to read the report. So that leads to fear and angst. It's challenging for the radiologist. They hedge from time to time, and that's the basis on which they operate daily. So it is a hard decision to eventually decide between an overcall versus a realistic risk assessment when they realize that there's something wrong on the CAT scan. It's challenging for the gastroenterologist. Thank you, James, for pointing this out. It's tough to decide who needs an endoscopic ultrasound and who needs to be surveyed and how. Of course, lastly, but most importantly, probably, it's challenging for the surgeon. Like any oncologic disease, it is a matter of balancing biology of the lesion, which sometimes is not known, with the comorbidities of the patient, and certainly location of the lesion. Pancreatic cysts reside in a very high-priced real estate. Pancreas is surrounded by very important structures, and obviously considering the technical aspects of the operations as well, which all together could lead to certainly a tough decision to make. So what are today's objectives? Well, we're going to learn about cyst management and surveillance of the pancreatic cyst. We're going to learn about the most common pancreatic cysts and their characteristic features. We're going to hear about what tools we have to help distinguish benign cysts from those with malignant potential, how helpful these tools are, and how to interpret them, and hoping that we learn more about identifying cysts at risk for progression, which certainly provides a great opportunity for early detection and cancer prevention. So a few words about prevalence and incidence. So overall, the risk of malignancy in pancreatic cyst is 0.5 to 1.5%, and the annual risk of progression is about 0.5%. So the good news tonight is that most pancreatic cysts are benign, even though we recognize and we find actually on imaging so many, most pancreatic cysts, the vast majority are benign. So if I want you to take a home message tonight, I think this is underlying that they are most of the times benign. Only a subset, though, has malignant potential. So in imaging studies, we've seen that prevalence is probably 2 to 15%. Autopsy data suggests a prevalence that's higher, as high as 50%. And there are some pre-malignant lesions that were recognized as the sole precursors of malignant transformation on cross-sectional studies. And those were introduced in 1996. The terms mucinous cystic neoplasm and intraductal papillary mucinous neoplasm were introduced at that time to describe the most common pre-malignant cysts. Historically, and interestingly enough, back in 1934, pancreatic cystic lesions were considered very rare, and they became recognized more common and potentially pre-malignant over the years, over the decades. So here's a bunch of studies that look at a number of radiologic studies, CAT scans and MRIs to again demonstrate the prevalence of the finding a pancreatic cyst, which could run from anywhere 1 in 40 to 1 in 3 imaging showing pancreatic cysts. Again, the good news is that the risk of cancer at the time of imaging is very low, 0.25%. A modern estimate of cyst prevalence, this is from the West Coast, shows us that if you're 80 years old, you have 1 in 2 chances to be identified with a pancreatic cyst on an imaging. If you're 70, 1 in 3. If you're 60, 1 in 4, and it goes just like that. If you are 50, 1 in 5. Majority of cysts are small. Obviously, the risky ones are those that are larger. And here's the map and placing some cysts on the pancreatic map. So if you were to have a cyst, probably the best one to have will be the serous cystadenoma. These are benign. They do not have malignant potential. They're easy sometimes to recognize if they're classic on an imaging. They have this central calcification, as you see on this pictogram. Again, they do not pose a risk unless they grow in size. Then we are dealing with occasionally with benign pancreatic cysts. Those are inflammatory cysts, which you could see in the tail. And then we're dealing with the mucinous cysts, which are the IPMNs. And you see here an IPMN of the main pancreatic duct, and then IPMNs of the side branch ducts. And the mucinous cystadenoma or pseudo-papillary neoplasm. So the mucinous cysts actually become the most common cysts that could transform into cancer. So talking about the benign cysts, they actually are about 15 to 25% of all the pancreatic cysts. And the mucinous cysts amount to about 50% of the cysts that are found incidentally on imaging for other indications. So when dealing with an asymptomatic patient who has a pancreatic cyst, one of the most important aspects is identifying what type of cyst we're dealing with. And obviously, considering the risk factors, comorbidities, and then what strategy will be employed to treat this patient or surveil or follow up over time. So on the left side here, you see the non-neoplastic cysts, the pseudocysts, the inflammatory cysts. In the middle section, you see the neoplastic cysts, which could be serous. These have no malignant potential, as in serous cystadenoma, or the mucinous cysts, which are the IPMN and then MCN, the mucinous cystic neoplasm. So from left to right, the malignant risk increases. And on the very right side, we have obviously the ductal adenocarcinoma and maybe a neuroendocrine tumor. So again, the risk of malignancy here is higher. Again, a pictogram to show that when we're dealing with a pancreatic cyst, we want to think first of what type of pancreatic cyst we're dealing with. What is the risk? Malignant, no malignant risk, or maybe cancers. And what is the strategy we're going to employ to manage the cysts? Again, on the left side, we have the benign cysts, the pseudocysts, the serous cysts. These carry no malignant potential. And then in the middle, we have the IPMN and the mucinous cystic neoplasm. These are mucinous cysts. Again, they're the bulk of cysts that eventually could lead to malignant transformation. And then on the right, the pancreatic cancer, the malignant lesions. So the strategy depends on the type of cyst, and obviously could run from no surveillance needed for the benign cysts to surveillance and surgery, a combination of those. In the mid category, the mucinous cysts, and obviously surgery when we're dealing with a pancreatic tumor. What are the common types of pancreatic cysts and characteristics? Again, there are about more than 20 epithelial and non-epithelial pancreatic cysts. However, the majority belong to the 6 histologic categories that you see here on this slide. And I'm going to slice it for you so you take away actually the message. The top 2 are benign. So they carry no malignant potential, 0, as you can see on the right-hand side. And these are the pseudocysts and the serous cystadenoma. Pseudocysts are usually diagnosed in the setting of pancreatitis. So patients have to have a history of pancreatitis. And the diagnosis of pseudocyst in the absence of history of pancreatitis should be made very carefully, since you might be dealing with a different type of cyst. The serocystinoadenoma, predominantly in women, occurs in 5th through the 7th decade of life. They are mostly asymptomatic. Again, they carry no malignant potential. And they have a typical presentation when they are classic. The challenge occurs when they're non-classic looking on the imaging. So the classic is sort of with a central calcification, and they have no communication with the pancreatic duct. They occur in the body. Pseudocysts, as you see, first category are mostly in the tail, in the left side of the pancreas. Then we have the middle category, the next two, the IPMN and the MCN, or mucinous cystic neoplasm. So these two are mucinous cysts. They're the most prevalent. Starting with the IPMN, these are with equal sex distribution. They occur in the 5th through the 7th decades of life. They may cause pancreatitis. So clinical pearl, when a patient presents with acute pancreatitis and we identify a cyst, doesn't mean that's a pseudocyst. It could be simply the cyst causing the pancreatitis. The IPMNs are of a few types. The main duct IPMN, which carries a higher malignant potential, and the branch duct IPMN. And there's also a mixed type that involves the main duct and the branch duct. So with the main duct IPMN, they cause dilation of the main pancreatic duct. And they have a hallmark when this is present, the fish mouth papilla. So when you look at the opening of the main pancreatic duct in the small intestine, you would see, just as in the photo to the right, you would see this fish mouth papilla with expression of mucin, since they are mucin productive. The mucinous cystic neoplasm, the second one in the mucinous category, tends to involve the tail. It could be... It carries a malignant potential, certainly, but they are less common than IPMN. So I want to highlight this early on so you understand that IPMNs is the battlefield. That's where most of the hedging and most of the debate goes on in terms of how to manage them, how to work them up, and certainly surveillance to eventually prevent cancer or intervene, actually, when they develop high-risk features, intervene at the right time for curative intent with surgical approach. So the mucinous cystic neoplasms almost exclusively occur in women, and they occur a little earlier in the 4th through the 6th decade of life. They're mostly asymptomatic, and sometimes they have this axial calcifications, but not all the time. About 1 out of 4 of the cysts will have that. And they are... showing ovarian-like stroma. So they tend to be unilocular and they have a specific presentation. So the last two cysts are less common, and I'm not going to go through them. So we'll move on for the sake of interesting cases we have next. I'll turn it to James.
Right. Thanks, Flora, for a great overview of these pancreatic cysts, and thanks, Dan and Karen, for the organizing this. So for the next phase, we just want to focus on how we approach these pancreatic cysts. And as kind of Flora rightly pointed out, yes, there's a very long list of pancreatic cysts, but really where the battlefield is in these IPMNs. And the vast majority of cysts that we're dealing with are likely going to turn out to be some form of an IPMN and likely some form of what's called a branch duct IPMN. So we're going to use these terms interchangeably when we talk about the cases and kind of going forward. That's really what the focus is on, not ignoring making a diagnosis of serous cystadenomas and so on, but really just trying to focus on this particular area. So when we approach these patients and trying to figure out what do we do, and a lot of these patients are picked up incidentally on scans done for other reasons, before we figure out, are we going to do nothing, follow them, or send them for surgery, we have to kind of make an overall assessment of the patient's condition, competing health risks, and so on. And then also look at some other pancreatic cancer risk factors like family history of pancreatic cancer. Does the patient have a germline mutation that would increase their risk of pancreatic cancer? And then it gets into the issue of making a decision and a shared decision-making process with the patient while we assess the risk. And the way we approach this is really trying to IPMNs into three broad categories. We talk about high risk pancreatic cysts or IPMNs, intermediate risk, or low risk. So we'll move to the next one. So with respect to the high risk IPMNs, these are patients that have cysts, but in addition, they have imaging features such as a very dilated main pancreatic duct, the presence of a solid mass, which would be very concerning for that this cyst has turned into a malignancy, and even biliary obstruction. And when we see these cysts, we're concerned. We're concerned that there's something significant and serious going on. And these are the sorts of patients that we would think about sending to surgery, or at least for a surgical evaluation. For the next group of cysts, the next slide, these are the intermediate risk IPMNs. And this is kind of the intermediate group. And these patients have features on imaging that are a little bit worrisome to us. They include things like, well, the duct is a little bit dilated, not very dilated, or there's a change in caliber of the main pancreatic duct, for example, or the cyst size is actually greater than 3 centimeters, which would strike most people as big, but it's a worrisome features. Maybe there's a small nodule in the cyst. Maybe there's some lymph nodes, or maybe the cyst has gotten bigger over time, over maybe, over a year, it's increased in size by greater than 20% or so. And these are patients that we classify as having intermediate risk factors. For the next slide. So for these intermediate risk factors, what we end up doing is evaluating them further. And typically, these are the types of patients that would undergo an endoscopic ultrasound, really to kind of parse out, is there something more serious going on? And I won't get into too much detail about the endoscopic ultrasound, but as most of you know, it's a type of endoscopy where the camera is passed down. We get very good views of the pancreas throughout its stages. And one of its great advantages is just visualization, but another advantage is the ability to biopsy these cysts. And when we biopsy these cysts, we're able to look at the cells that we get back from the cyst fluid, but also a variety of markers, including DNA markers that have a very high specificity and sometimes sensitivity for not just making the diagnosis of it being a mucinous, but also maybe telling us that this is potentially a high-grade dysplasia or even a cancer. So endoscopic ultrasound is very useful, again, for teasing out these intermediate risk pancreatic cysts. Next slide. But really kind of what the main battle to get back to this issue is the other group. These are the low-risk IPMNs. So these are your cysts, again, presumed branch duct IPMNs that don't have a single worrisome feature. They don't have a single high-risk feature. And these make up the vast, vast majority of patients. These are the 5 millimeter, the 10 millimeter cysts that you see on routine scans done for other reasons. And yes, they are presumed branch duct IPMNs. But you can see from this data that if you were to follow this group of patients for long periods of time, or up to 5 years, yes, some of the cysts will get bigger. So some of them will increase in size. The vast majority do not. The vast majority do not end up ever requiring surgery. And the vast majority never develop into pancreatic cancer. And therein lies the challenge, because it makes up such a large volume. Patients are worried, we're worried, everybody's worried. So next slide. So as a result of this, as we kind of work through this process of trying to stratify patients into, are they high risk, are they intermediate risk, or are they low risk, you see how it falls out. So for the high risk patients, this is the group of patients that we would say, hey, we're concerned about this group based on their imaging. We need to have a multidisciplinary discussion. We need to have our surgical colleagues involved in making decisions. Is this something that needs further workup and potentially surgery? For the intermediate risk group, we do further investigations, including endoscopic ultrasound. But for that low-risk group that's there, again, the vast majority of group, if we're comfortable with the diagnosis, if we're comfortable with the imaging, then we get into the discussions of saying, well, maybe we're not going to do surgery, maybe we're not going to do endoscopic ultrasound, but we're going to have to follow you. And how do we follow you is a real challenge. Next slide. I can cover these. So the key points that we've talked about thus far are the fact that pancreatic cysts are common, discovered at an increasing rate. The goal, which I think has to be emphasized, is that we're trying to emphasize that small percentage of cystic lesions that are associated with a substantial risk of cancer. Combinations of imaging, symptom assessment, laboratory tests can help distinguish several benign cysts from the low, intermediate, and high-risk cysts that we talked about. EUS can be considered for patients that have equivocal findings when we're trying to figure out the diagnosis, but really for those intermediate risk cysts. And there is a really significant role for endoscopic ultrasound and sampling these cysts to not only diagnose, is it a serous cyst, is it an IPMN, but also to risk stratify. And then this gets into discussions of, and we'll hear from Dr. Kunstman, about surgical evaluation as well as surveillance for low-risk cysts. Next slide. And I'll hand you over now to Dr. Kunstman.
I'll be happy to introduce the case, the first case for John. So this is a 90-year-old male with worrisome changes in presumed mucinous pancreatic cyst. He has a history of previous urologic malignancies, prostate cancer, testicular seminoma, and remission developed hematuria in 2022, which led to imaging, and that revealed multifocal pancreatic cysts. He doesn't have any history of pancreatitis or jaundice, no family history of pancreatic or BRCA-related cancer, no diabetes, no exocrine insufficiency. John? Oh, additionally, some past medical history, skin cancer, atrial flutter, dyslipidemia, GERD, hypothyroidism, glaucoma, by surgical history, patient had right orchiectomy, radical prostatectomy, an inguinal hernia repair. The medications are as listed. He is married, semi-retired. He consumes one standard ETOH alcoholic beverage a day, and he's a 12-pack a year smoker.
Yeah, I would say just even before we advance the slide, if we could go back, I mean, and it's nice to meet everybody, and thank you for the lovely invites, Karen and Ann. I think from my perspective, obviously a 90-year-old male being referred to surgical oncology clinic might raise some eyebrows, but the history here is really interesting. It was incidentally found, and then to Dr. Farrell's points, he doesn't have any of those worrisome findings right away on the history, like pancreatitis, jaundice, a strong personal or family history of malignancy that might be related to the pancreas. So, right away, I'm already thinking this might be a lower risk lesion, and then maybe we can go to the imaging now. So, he was 88 when this was found. So, just looking at his scan, I don't know if we can scroll through it or not. There we go. It's probably going to go right past it since it's on a loop, but I'll just kind of describe as it goes through there. The pancreas there in the middle, you can see the calipers going past quickly. Basically what we see from my perspective is 3 small cysts. They're all very bland appearing. The largest is 16 millimeters in greatest dimension. There was no additional features that made us worry, like main duct dilation or nodularity within the lesion, like Dr. Farrell was referring to. There was a tiny area of calcification, but that alone doesn't convey any significance. Now, since the patient does have an excellent quality of life, he's still working, in fact. His performance status is excellent. Despite his advanced age, he was recommended to undergo surveillance. So we can head on to the next one. So as many folks do, he got an early interval repeat imaging study at 6 months because, as alluded to by Flora and James, the size is a risk factor, but one independent risk factor is the rate of cyst growth. So our practice is typically for a presumed new IPMN without any other worrisome features is to get a 6-month interval scan to determine whether it's one that's rapidly growing or not. There was a little bit of growth, 19 millimeters, but no other worrisome features. I would just point out that scan was ordered without contrast, which is perfectly reasonable for surveillance. But if there are some features that you're following in particular, contrast can be helpful because enhancement of a nodule or enhancement of septations within a nodule, those are risk factors. So he didn't have any of those, so I think an MRCP was perfectly reasonable. And based on those findings, he was recommended to get another scan at a 1-year interval. So that was done in 2023, as you can see. The largest cyst had grown again a little bit. The typical natural history of these cysts is slow progressive growth. This time, the largest was 22 millimeters, again with no worrisome features. Many times in patients that are perhaps, younger or, really exquisite performance status, that 2 centimeter threshold oftentimes triggers an EUS. It did not in this case after a shared decision-making conversation with the patient, which I think was very reasonable, but another annual surveillance interval was recommended. That scan, which we'll show on the next slide, I believe, showed quite a bit of change. So you can see there, this is the MR. Now we're seeing multifocal mixed phenotype with both the main duct dilated and multiple cysts clustering together in essentially the entire pancreas from the uncinate all the way to the tail. So a number of concerning features of progression with just 1 year of surveillance, and he was recommended to undergo an EUS. So he got that endoscopic ultrasound that noted the cysts did appear to be mucinous upon aspiration, and there was some nodularity in the junction of the body and the tail that was biopsied. That biopsy you can see there, read out as, again, a mucinous cystic lesion, not unexpected. But there was dysplasia, and that dysplasia was high grade. High grade dysplasia is essentially the pathologist telling us that they're seeing pancreas cancer-like cells, they're just not seeing it invade into the underlying pancreatic parenchyma still within the cyst itself. Generally, this is considered a very high-risk finding, and it triggered a referral to surgery. So I just want to talk briefly for a patient like this, what types of surgeries might be a consideration. You can see on the right side that cartoon there again showing what we would call a mixed IPMN, where there's main duct involvement and branch duct involvement. And in this case, again, pretty much the entire pancreas was involved. The red star is about where it is, where the dysplasia biopsy was taken. So when we're talking about surgery for IPMN disease, first and foremost, the question is there cancer there? Now, in this case, we didn't have an overt diagnosis of cancer, although we did have a diagnosis of dysplasia. Certainly with any operation, we want to try and minimize the future risk that IPMN could convey to the patient. So in his case, the entire gland was affected, so there's going to be risk regardless unless he undergoes a total pancreatectomy. Now, we also want to minimize any complication risk. Generally speaking, that means a distal pancreatectomy is a lower risk operation than a Whipple procedure, but certainly the cancer and the risk considerations supersede that. And then just alluding to that total pancreatectomy, we also want to try and minimize any long-term effects on the patient's digestive health or metabolism. Now, certainly patients can and do develop diabetes or exocrine insufficiency after a pancreatectomy of any size. So it's important, especially from a primary care standpoint, that those considerations are discussed both with the patient and their primary care provider beforehand. And if you can mitigate some of them by, say, an additional referral or additional conversation with a diabetes specialist, et cetera, a nutritionist, those are steps we certainly take in our multidisciplinary clinic. So as far as the operations themselves, if you can hit the next button, Whipple procedure is the resection of the pancreatic head. Now, as you may or may not know, the reason a Whipple procedure is done the way that it is, with the duodenum being resected as well as the lower part of the bile duct, is all those structures, the duodenum, the pancreatic head, and the lower portion of the bile duct share the same vascular supply. So during the operation, the gastroduodenal artery gets ligated. As a result, all of those structures then need to be removed to unblock and reconstructed. Go ahead and hit next. Conversely, a left-sided operation or a distal pancreatectomy doesn't require the reconstruction that one would have with a Whipple procedure. You simply close the divided neck of the pancreas, either with sutures or staples or a number of different techniques. Generally speaking, when this operation is done for any risk of malignancy or a known malignancy, we perform a splenectomy concomitantly with that. Reason being, almost all of the lymph nodes in that area cluster along the splenic artery and splenic hilum. So removing the pancreatic tail alone for a cancer or possible cancer is not an oncologically adequate operation. Next, yeah, and then a total pancreatectomy. So just a quick word about that, for patients with the entire gland being involved with IPMN, that is a consideration, especially in a younger patient where you expect them to develop a cancer in any remnant pancreas. I would say it is an operation that obviously has severe long-term metabolic effects for the patient. That being said, in the era of exocrine enzyme replacements and insulin pumps, this has been well studied in our literature. Patient quality of life is actually very good. But it does take 6 to 12 months to resume their preoperative quality of life after a total pancreatectomy. So why don't you go ahead to the next slide? So this patient, after a period of shared decision-making and imaging, despite his advanced age, was interested in undergoing surgery. I felt it was appropriate given that his performance status was as good as most 60 or 70-year-olds. And I felt his other medical comorbidities could be well managed. And again, it was a decision between the patient, myself, the gastroenterologist, and the primary care physician. So he underwent an operation where we removed the left side of the pancreas, and we extended it a little bit because we wanted to remove as much of that main duct that was affected by IPMN, but we didn't want to subject him to a total pancreatectomy. He had a little bit of postoperative ileus, but essentially no complications. The main complication we watch out for in any pancreatic surgery is a pancreatic fistula or leak. He did not have that. You can see the gross specimen there that's been divided there in the pathology lab, and right dead center in the middle, lo and behold, he actually did have a fairly large adenocarcinoma arising within the IPMN. The surgical margins were negative, so it was completely resected. He did have 1 out of 48 harvested lymph nodes that had regional disease. So, after surgery in this particular patient, systemic chemotherapy is generally considered standard of care for any adenocarcinoma of the pancreas. However, again, at his advanced age, there's certainly pros and cons to consider with the toxicity for the multi-agent regimens we generally use now. So that's an ongoing discussion. He did not have any issues with diabetes or exocrine insufficiency. People do need to be vaccinated if they are having a splenectomy against encapsulated organisms. Now, he had an excellent primary care physician, so he was already actually vaccinated for his pneumococcal vaccinations, but we did give him meningococcal and Haemophilus vaccinations, and certainly he'll undergo surveillance. I think the take-home points for this case, this is actually a great demonstration of everything that Flora and James had talked about. He had a lesion that had some risk. It was felt to be appropriate to surveil him. He had some changes that triggered a further workup that led him to the operating room. And ultimately, we were able to resect his pancreas cancer before it metastasized. So, again, he was 90, but I do think it was the right thing to do, and certainly he'll enjoy a survival benefit from this intervention. Okay, so I'll try and get through the next couple cases a little quicker.
Our second case is a 64-year-old female with history of ankylosing spondylitis and increased epigastric and back pain. So HPI is significant for chronic back pain, but recent increased episodic pain. And careful ROS revealed that patient had postprandial exacerbation. The primary care doctor ordered a CT of the abdomen and pelvis, and that revealed a pancreatic cyst. Also relevant is that patient had a remote history of pancreatitis attributed to gallstones, no history of jaundice, family history of breast and GYN cancer, and no history of pancreatic cancer, no diabetes, and no exocrine insufficiency. Additional past medical history significant for asthma, diverticulosis, hypertension, Graves' disease, and attention deficit disorder. By surgical history, she had cholecystectomy, tonsillectomy, hysterectomy, breast biopsy, home medications, as noted, and by social history, she's married, no tobacco, and consumes 1 to 2 alcoholic beverages per week.
Okay. So yeah, I think hitting all the important points again, in this particular case, the imaging shows a somewhat concerning cyst for somebody that had previously had imaging with no cysts in the past during workups of her chronic back pain and that remote history of cholecystectomy. Here we have this 3.4 millimeter, 34 millimeter cyst. There's no clear nodularity, but quite thick walls with some enhancement. In this case, kind of contemporaneously, the primary care physician actually referred her to both gastroenterology and to my clinic with these findings. And so I had the luxury of having endoscopic ultrasound being done at the time she presented to my clinic. And as we had the ultrasound done, but we didn't have the biochemical analysis just yet. So we spoke to her about the possibilities of IPMN or MCN with a picture like this. But what really stood out to me was the history of pancreatitis in the distant past. Now, again, that had been attributed to gallstones, which may have been the case, but she had now undergone cholecystectomy. But the postprandial exacerbation of her pain really made us wonder a little bit, because pancreatitis that's attributable to a cyst, as alluded to, can sometimes be a diagnostic dilemma. Is the cyst causing the pancreatitis, or is the cyst secondary to the pancreatitis? So we sent her for the EUS, and those findings are as listed there. In this case, the CEA on biochemical analysis was about as close to 0 as you can get, and the cyst fluid amylase was quite high, and a biopsy showed inflammation only. So next slide. The way that we would interpret that is as a pseudocyst rather than a mucinous cyst. Interestingly enough, as we were awaiting those biochemical results, she actually ended up in the emergency department after going to a holiday party with serum lipase of over 1,000, as you can see there, after having a few glasses of red wine. So in this case, the diagnosis was made of acute on chronic pancreatitis with pseudocyst formation. We recommended the patient to have a bland diet and stop drinking. And she basically returned to her baseline level of back pain, was quite satisfied. And we did get a follow-up scan to ensure that things were improving, which it did. The cyst was gradually reducing in size, which is the natural history of most pseudocysts that are under about 5 or 6 centimeters. So this patient needs no intervention and also needs no surveillance other than some reminders to be cautious from a pancreatitis standpoint. And she moved on with her life. So
Our next case is a patient with a worrisome cyst and a frail patient. This is a 73-year-old female with left lower quadrant pain who underwent imaging revealing diverticulitis and pancreatic cyst. The diverticulitis was treated non-operatively. The patient is wheelchair-bound, secondary to chronic low back pain and severe degenerative arthritis. She has no history of pancreatitis or jaundice. There's no family history of pancreatic, BRCA-related cancers. She has long-standing type 1 diabetes. She's actually on an insulin pump, and she has no exocrine insufficiency. Other past medical history, dyslipidemia, GERD, obesity, hypertension, radiculopathy, bisurgical history. She had the gallbladder out, appendectomy, and a foot fracture that was operated. Medications, as noted, statin, insulin pump, an SGLT2 inhibitor, dapagliflozin, blood pressure medications, anti-inflammatory, pregabalin, tramadol, probably to manage her pain. And by social history, she's widowed, no tobacco or ETOH use, and lives with an adult child.
So this was an incidentally found lesion. Just for the record, her diverticulitis did resolve with antibiotics only. And she was referred to my clinic. And her pancreatic, she really had a pancreatic body cyst, a little error there on my part, that measured over 3 centimeters with some enhancement in the wall, no clear nodularity. but certainly one that would be in that intermediate risk category, as Dr. Farrell was delineating earlier. An EUS was performed that confirmed the diagnosis as an IPMN. You can see the CEA level is quite elevated. The amylase level is low. A biopsy was performed. The epithelium was bland. No evidence of dysplasia. So here we have an intermediate risk lesion. So what's to do next? Go ahead and next slide. Yep. So the diagnosis confirmed as a branch duct IPMN. As Flora was alluding to, this patient was quite frail. When we evaluated in our clinic, she really had challenges with the get up and go frailty test. I would call her from a oncologist point of view, ECOG 2 on a good day, kind of 3 on a bad day. She did ambulate some at home. And again, the diagnosis is a large branch duct IPMN, but without additional worrisome features. So we had a long discussion with her, and these can be challenging discussions, but it's important to understand what people's values are, how they view their quality of life, etc. Certainly, even a distal pancreatectomy, if done laparoscopically, that risk is still considerable. It's a major operation, and we really felt that risk was prohibitive for this particular patient unless there was clear evidence for a cancer there, and even then it might not have been the right thing to do. So oftentimes the way that conversation gets steered is, if we were to discover a cancer, we know that you don't have a cancer now based on our best guess. Would you want that cancer to be treated? Would you want chemotherapy? Would you want radiation therapy? If the answer is yes, then it's very reasonable to consider surveillance, with the understanding that if there was a change that was concerning before any treatment could be rendered, they would need to have a repeat biopsy, and there would be options for them that they could choose. But if the answer is no, when explained to a patient in this way, they actually oftentimes do say no. They say, yeah, doc, I'm just not interested in that chemotherapy or radiation. If something happens, you can manage my symptoms, but I'm not having surgery. I'm not having chemo. And expectant management is very reasonable, and we give these patients things to watch out for and contact information. But as said several times in this talk, these are frequent findings, and this is really a disease of older patients. So deciding where we want to deploy our surveillance resources is oftentimes a really meaningful conversation to have. In this particular case, she did opt for continued surveillance, but at a low frequency. So we'll pass it back to Dr. Farrell.
Right. Thanks very much, John, for those very interesting cases. So I think it's also important to state, as most people realize, that the vast majority of all cysts, not just the IPMNs, never undergo any sort of surgical management, but yet we make decisions about following them. And this is often a very confusing area, and the guidelines have been changing and will continue to change. The references here, if anybody wants to email me, I can send you the actual article with this table in it. But basically, surveillance for patients that you decide or you're going to survey is really based on the size of the lesion. And so the smaller that the lesion is, the more likely you're going to use non-invasive imaging studies like MRI, MRCP. The bigger the lesion gets, you're going to include endoscopic ultrasound, because those are lesions you're concerned about, maybe not planning to operate on, but you're worried about. And then over time, the surveillance changes as well, whereas up front, we kind of get more frequent imaging because we are concerned about trajectory, trying to understand the cyst. But over time, we back off, especially if there's stability. And as we'll mention very briefly at the end, there may now be some discussions about stopping surveillance based on stability as well. Next slide. I have 2 cases, but I'll quickly go through them so you can just keep forwarding. And you can keep forwarding here. This is just one of those cases where it's a small cyst, and you're saying to the patient, oh, probably nothing will happen, but you can stop there. But over time, this patient's cyst grew and ended up undergoing endoscopic evaluation. The pancreatic duct got bigger, and so this is a young patient with a relatively small cyst, like 11 millimeters to begin with. But ultimately, because it grew and the duct size was big, the patient actually elected for surgery. So to go to next slide. And next slide. And at the time of surgery, again, for a patient that started with a small cyst over time, go back one slide, this ended up being an IPMN with high-grade dysplasia. Next slide. This is one of the more challenging patients. This is like an 81-year-old gentleman. So you can begin to kind of have that discussion saying, well, should this patient even really be in surveillance? But this is your pickleball playing 81-year-old who comes into clinic and wants everything done and is adamant that they want everything done, and often a very difficult conversation. But a patient with a relatively large cyst, and we presumed it was branch duct IPMN and greater than 3 centimeters. And so we do these alternating strategies. But we're constantly saying to him, look, we'll reevaluate this. Next slide. So in fairness, 2029 went by, 2020 went by, 2022, 2023. He's now developed a second cyst in the uncinate process, and his original cyst has got a little bit bigger. Next slide. And so he finally comes back into clinic, and this time now he's 86 years old, still healthy, still tells me he's playing pickleball. But we want to have one of these discussions, and it's kind of part of the broader discussion about, like, I think it's easier for us to get into surveillance with patients, but the really challenging thing is, how do we stop surveillance with a lot of these patients? It's an issue if it doesn't make sense. It's resource utilization. It's comparison with, competing with their other medical issues. And so we had the conversation with this patient. We said, look, you're 86 years old. I know you're very healthy. I know you want to go all the way, but let's bring some sanity to the situation. And he negotiated himself to one final endoscopic ultrasound, rightly or wrongly. And we said, look, if that's completely normal, we're done. We're going to stop. Next slide. Long story short, we sampled both cysts. One of them had high-grade atypia in it, and the other had a molecular marker in the cyst that's very suggestive of an advanced neoplasia. High-grade elected to stop surveillance because of other cardiac issues that arose. And so that made the decision. But I use this case just to illustrate how challenging some of these folks are, especially when we're getting into the time frame when we should really be backing off surveillance, not just for pancreatic cysts, but probably for other diseases as well. Next slide. So back to this kind of bigger topic of stopping low-risk IPMN pancreatic cyst surveillance. So for sure, we're not applying this or not having this discussion for patients with the sorts of patients that John ends up seeing, patients with large cysts, patients who are on their way to surgery. But there are these groups of patients with 1 centimeter, 2 centimeter cysts. And now there's an evolving discussion that perhaps if they are of a certain age, maybe over the age of 75, if the cysts are stable for 5 or 10 years, that maybe we should stop surveying them because their long-term outcome is very similar to the general population. And so this is beginning to creep into guidelines, and there's more and more data accruing. So I think people need to be aware that, and again, it's probably one of the more challenging things we do in Panc-Cyst Clinic is having frank discussions with people about stopping surveillance. Next slide. And so when we think about stopping pancreatic cyst surveillance, there's multiple factors that come into play. There's one group of factors which obviously has to do with the pancreatic cyst itself. What type of cyst is it? Has a patient had surgery for the cyst before? What does a cyst look like? Do they have low-risk features or are there high-risk features? The issue of cyst stability is very important because people are beginning to understand that maybe if cysts are stable over a long period of time, it denotes a certain biology that may not progress further. But then there's patient factors, and we don't really have an absolute age yet. We don't say 75, we're done, 80, we're done. But we certainly take age into account. We take comorbidities into account, also because some of the comorbidities influence progression, like diabetes. And then, as John alluded to, like patient preference, this is kind of shared decision making. This is like, well, what's important to you? Do you really want to be coming in for endoscopies and MRIs for the next 5 years? But there's other issues, maybe race and ethnicity kind of plays into decision making, as well as ultimately resource utilization from a health system perspective. So this is an evolving topic, and I will leave you with this note, is that there's a large number of very expert and well-trained individuals at Yale, both on the surgical side as well as on the gastroenterology side. But also one of the beautiful things about pancreatic cysts, it's a really multidisciplinary specialty. So we have wonderful pathologists and radiologists, who help us manage these patients. And so I think the sorts of patients that we end up seeing in clinic in terms of co-management with primary care include, next slide. is when it comes down to trying to figure out what type of cyst it is, and we can certainly help with that. And again, the vast majority of times, as I said, these small cysts turn out to be branch duct IPMNs. But also, how do we help with those branch duct IPMNs? At what point should we be thinking about surgery? When should we be thinking about an endoscopic ultrasound, especially for those intermediate features? But actually, what I think is the larger and bigger picture and the big problem is trying to figure out what to do with all the low-risk branch duct IPMNs and decisions about, do we start surveillance? How do we survey? How frequently do we survey? And when do we think about stopping surveillance? We can, if
I
there's
was
any.
just I was just answering one of the questions in the chat, but James, Flora, curious before I type anything to Jill. The question is, can you talk about how to use A1C and CA19-9 levels? Should PCPs be ordering them for cyst follow-up or not? That's actually a really good question. There's arguments for following them and for not. They generally are not included as firm recommendations in the guidelines. My personal practice is for somebody who is non-diabetic, we don't follow the A1C at all. In terms of cyst surveillance, James, I'm curious what you do. And CA19-9, I like to get a baseline level and correlate it with any imaging changes. Keeping in mind that 19.9 should always be sent with concomitant LFTs.
Somewhat similar. I think it's to go to the end of the discussion and say it's a very practical issue from a patient management perspective, because we get the results back. And a lot of our patients have mildly elevated hemoglobin A1Cs, mildly elevated CA19-9s that leads to other tests. And so the question is it really worth going down this road? We know that CA19-9 is not a great tumor marker for pancreatic cancer, but I do agree it's good to have a baseline, just in case it rises later on in the patient's course, because you're going to be following these patients for 4, 5, 6, 10, 15 years. The hemoglobin A1C in the diabetes is a slightly different story, because there's growing data about the role of just diabetes in accelerating progression of patients with branch duct IPMNs, but also the role of just new onset diabetes as a risk factor for the development of cancer. So it works kind of both ways. Yes, it can be a good biomarker, but it can also be a way of trying to decrease that risk in these patients who we're surveying. We don't have all the data there, but I think it is worth following. I think there are a lot of patients out there who, I think can obviously benefit from, healthier lifestyles and better controlled blood sugars. It's certainly challenging, but I do actually monitor the hemoglobin A1C a little bit more closely than the CA19-9.
Fantastic. Well, we're on the hour. Flora, did you want to say something?
Yes, I have a question
here?
for James, and that pertains to how far are we in research these days with endoscopic ultrasound and using of laser optical cameras to get a microscopic view of the cyst wall? And is that in development? Is it coming down the pike soon, or using AI as well to analyze the images and to identify the high risks eventually with the cyst transforming?
Yeah, no, there's definitely a lot of activity in the area. We do have the ability to put small cameras into cysts to get more imaging. It's still considered a research tool, may not well be applied to the broader spectrum. I think there are still exciting developments in understanding how cysts develop and how they progress, and understanding if there's diagnostic tests like molecular tests that could help us understand that. And of course, you can't get through any conference these days without mentioning the word AI. And so, yes, AI is right there in analyzing and co-analyzing with radiologists, MRI images, and CT scan images to kind of quickly get to what are the worrisome features, what are the high-risk stigmata, are things being missed? And the very kind of scary piece of data about the fact that for some patients who go on to develop cancer, if you go back and use AI to look at their imaging studies with cysts, 12 months, 18 months before they develop cancer, that there may be signs there. So I'm classically a late adopter, but when it comes to stuff like AI, I think there's great potential. And so you'll be seeing a lot more about AI and imaging recognition and so on when it comes to pancreatic cysts and pancreatic
good topic for a future Smilow shares. But I'm going to have to close this. We're after the hour. Thank you all for attending, and thank you so much for putting on this program. I learned a lot, and take care. Bye-bye.
Thank you. Bye-bye.